Saan ba tayo? Still on
Alright,
message.
so the next one, we are going to be discussing chest tube. So I just saw this. Oh, I forgot. Before I forget, I'm gonna mention this already so that I don't forget. So on France, page 102. Okay, the main question on France is it's select all that apply manifestation. Okay, so make sure that you study the manifestations of France and ulcerative colitis because the focus on the NGN primarily a select all that apply question is manifestation of inflammatory bowel disease.
France and
It's
what?
very vague because you know when you say inflammatory bowel disease, it can be either Crohn's or ulcerative colitis.
Ulcerative colitis.
So make sure that you're studying the what? The manifestation. So that's page 102. That's Crohn's and ulcerative colitis is. What's that? Oh, next to each other. What's the bottom? Oh yeah, right there. That's right. So it's right there. They're together. Crohn's and ulcerative colitis. Maybe one, but it's manifestation. Select all that apply. Select all that apply. Okay. And then the other one, there's one more NGN that I just want to make sure. The focus on this one though is called peptic ulcer disease. So it's page what's page? Peptic ulcer. There you go. PUD 100 to 101. So peptic ulcer disease 100 to 101. All right. The focus is two things, and it's also select all that apply. Remember yesterday, cues and analysis of cues on the nursing clinical judgment model, the first two questions of the NGN, that's how it's going to be asked. So remember yesterday when I showed everyone the prostatectomy, where the first question was analysis, the first question was cues, but they were asking you which of the cues is something that requires prioritization or follow-up care. That's basically what it's going to be. Okay? On peptic ulcer disease. So 100 to 101. So which among the cues would require immediate attention or follow-up? Okay. And then the other one was the analysis of cues where it was asking I think why those symptoms are there or which of the symptoms are actually getting worse, right? Or something like that. That's another one. So the focus is analysis of cues and cues. So signs and symptoms and analysis of the signs and symptoms. And which should you prioritize? So let me give you an example. What is one of the main problem with peptic ulcer disease that's a big priority? We have peptic ulcer. Bleeding. Right? So bleeding, especially what? Sudden onset of severe pain with hypotension and tachycardia, that's an immediate what? Follow-up. That's something that you have to immediately follow up or check because that's the problem. I think the most dangerous complication of peptic ulcer disease, if you look at it, is perforation. Right? When you have peptic ulcer perforation, it goes through, right, that layer of the stomach and someone ends up hemorrhaging from the inside. So that's an example of one of the things that you want to fix. You know, it's pretty much priority.
Preparation of bleeding.
Okay, but there are other stuff here. Like I said, focus on page 100 and 101. Okay? Alright, so that's it. That pretty much completes all of our stuff for NDA. Yes.
So, I'm sorry to go back to whatever you're saying with the restraint thing. So I found the question.
The what?
The question that they're talking about. It says a nurse in the acute mental health facility is caring for an adolescent who is exhibiting excessive behavior. Which of the following actions should the nurse take after applying physical restraints? A. Plan to remove the restraints as soon as the client's calm. B. Ensure the provider has signed the prescription within the restraints within 48 hours.
48 is wrong, right?
Huh?
48 is wrong. So
It's
you
too
already
long.
know that one you won't pick that.
Offer the client nutrition snack after 4 hours, or D. Monitor the client's range of motion every 60.
Every what?
60 minutes.
Every 60 minutes.
And that's too long for an adolescent.
I think, if I'm not mistaken, and maybe this part of that is the snacks.
No.
Is the snacks. What
No.
was on that one?
Plan to remove the restraints as soon as the client is calm.
Yeah, because
Was
that's what I
that
did.
the actual answer on the test, though?
That's the actual answer on the test because it says planning to remove the restraints as soon as the client is calm is the correct action. Restraints should be used for the shortest duration necessary to ensure safety, but here's where the other part is. Monitoring the client's range of motion every 60 minutes is the correct action, but they have it as wrong. When a client is restrained, it is essential to monitor the physical well-being regularly. The problem is that it's having with it is ATI does it where it says applying. So we get the rationale.
I don't think that that's the right answer, though. I'm gonna check that exam because
Has to be.
here's the thing. You cannot remove
Someone's
the
having
restraint immediately as soon as the client is calm, because the client can just calm down and
then hit you.
still be aggressive. So that's why it should not be the right answer. So I'll check up on that.
But we're on
Check
ATI
out that,
Memorial,
because why?
where they don't do
The
that.
word immediately remove it as soon as the client is calm. You didn't do your what? You didn't
Assessment.
do what? Your assessment before removing the restraint. And that can be dangerous because that client can just calm down, and then as soon as you remove it, what
Bam!
happens?
Punch you in the face.
It becomes aggressive. So I'm gonna take a look at that because I don't think that that's actually the right answer. The right answer, what I'm thinking, is really the snack, because what they've been saying is if you give the snack, it actually then it's just snacks. It's not really the food. What they're saying is snacks actually helps in allowing the client to become more calm and less aggressive. So I'll take a look at that, though. I'll take a look at it.
So this is sound right.
Can you send it to me? Yeah. Send it to me because I doubt that the answer was to immediately remove it once the client is calm. Yeah, because remember, if you remove it,
But it's not saying to remove it immediately once the patient is calm.
Yeah.
But that's where I'm saying, because like the problem is with it, because that question's come up twice. It has to do with the mittens, and the mittens one was talking about doing the for where the snack part. It was to check the finger length. It's supposed to be one finger underneath, and then the other part of
that
that.
was wrong. That was wrong.
Yeah.
Right? One finger.
But then, so it's remove them as soon as they're calm.
But
That's what I'm saying.
no,
Yeah.
I can't really look at that. I'll have to check it with API and really see if that was the actual answer. But send it to me so I can do the check.
Dr. Montano, I picked that and it's not in my That's what?
That remove it immediately when the patient is calm.
Yeah, that sounds right. Because we're in ATI Memorial.
Let's take a look. Let's take a look, guys. So that we
It's
can get
personal
that.
now. It's personal now.
But yeah, let's take a look at it. So hopefully we'll close up our answer to this. Let's see. Restraints.
Nasaan yan? Client safety maybe?
Page 66 or 185. Let's take a look, guys. 66.
Restraints.
66. Let's see here. Restraints. Here we go. Nursing intervention. Okay. Implement non-pharmacological measures such as distraction, frequent observation, or diversion activities. So yes, so we have to make sure before we use a restraint, do other things first, right? Before a physical, and then the last one is chemical, right? Let's take a look. Prior to application, review manufacturer's instruction about the correct application. Next one is notify the provider immediately when the restraints are implemented. Remove the restraints and assess the client every 2 hours. Assess neurovascular and neurosensory status every 2 hours. Leave the restraints loose enough to prevent injury. That's so vague, right? Because why? It has to be. This book is getting on my nerves. Yeah. Leave the restraint loose enough. That is really like very vague answer.
Yeah, like colors.
Always tie the restraints to the movable part of the bed. We said that.
Bed frame, yeah.
The bed frame, at least that's consistent. Reassess the need for continued use. Providers may renew the prescription with a maximum of 24 hours. So that's consistent with the other option, though we can't do 48, right? Behavior making restraints necessary. Okay, document alternative attempts to the client's behavior while in restraints, types of location of the restraints, frequency and type of care. Restraints or seclusion should never interfere with treatment, be used for staff convenience. Wow, that answered our question. Okay. Stop there. Let's look at 185. 185. Sit here, restraints.
No.
Doesn't have a lot. Huh? Any
No.
other thing, guys, that you found?
No, this is about reporting abuse.
187. And
No, there's nothing there.
198. If we don't get it, like I said, I will check and I will get back to you.
It's
But,
diabetes.
we'll check at those two alternatives of removing the restraints immediately once the patient comes down, or the other options about the snap.
In the mental health, the answers are like vague, but one of the books that all interactions with the client should occur in behavior that will provoke or reduce institution or.
Correct. I don't doubt that, because that's actually the goal. The goal is not really to use it, but to remove it immediately as soon as you can. But the thing is that right to say immediately remove it as soon as they come down? Because, again, that is we are sensitive.
It doesn't.
Right? But yeah, I'll research on it on our first break. I'll take a look at that question. And then, but let's continue so we can finish our topics, okay? But as soon as our break is done, I will address that question again. Did you send it to me, Gabe?
Yeah, I just
You did? Alright, thank you.
Did that say
Alright, so let's go and take a look at this, our next topic. A nurse is checking the suction control chamber of a client's chest tube and notes that there's no bubbling on the suction control chamber. Which of the following actions should the nurse take first? So first,
check if it's on. Yeah, check if it's on.
the answer is letter
B?
B. Correct. So, very important. This is how they're gonna ask you this. So the question on this is plan of care for someone who has a chest tube. Now remember, if you think about it, who or which condition requires a chest tube?
Pneumothorax.
Someone who has pneumothorax or chemothorax.
Pneumothorax.
So you have either fluid accumulating in the thoracic space, which is the chest space, or you actually have air accumulating in the chest space, and what it's doing is actually crushing the lungs. That's what it is, right? So it's crushing the lungs, it's preventing the lungs from expanding. So the purpose of the chest tube is to allow the lungs to what?
Expand.
To re-expand. To re-expand. Now, that purpose is what we monitor constantly for a patient that's on a chest tube. And we do that by looking at, other than assessing our patient, the 3 chambers in the chest tube, right? You remember, what are the 3 chambers in a chest tube? So a chest tube
There's
would
the
look like
suction.
a box, right? Like this. And it's actually divided into 3 chambers. Right? We have the suction, and then here you have the water seal, right? And then here you have the collection chamber. Okay, you have the collection chamber. Alright? So, suction, water seal, collection chamber. Okay, now, these are the 3 things we monitor other than assessing the patient to make sure that the patient's condition is getting better. But there are specific things that we monitor. So going to this question, one of the very specific things that we monitor in the suction control chamber is we want to see that there's actually what? Bubbling.
Bubbling.
That's what we want, right? We want to see continuous bubbling because that means that the suction is sealed, right? And it's actually connected, and you know that the actual device is working. So you want to see suction. So in that situation, right, if the suction tube notes that there's no bubbling, what's the thing? Check, there's a problem, right? Here's what I want you guys to remember. On the exam, our exit, on our exit, let's say I add another letter here. Alright? On our exit, if I add that right there, that would have been the first answer to pick.
Mm-hmm.
Okay, why? Because if there is any problem on the chest tube, your priority is what?
Check the patient.
Before you check the device. Okay? So if there is a problem, then the best answer is to what? Always go for checking the patient first before you check the device. Now, here's another version. What's the answer?
Continue to monitor. C. Continue to monitor.
So in this situation,
Expected finding.
yes, this one. Alright. So in this situation, right, we remove the word no. So what happened? The situation now became what?
Expected finding.
Expected. It's
Yeah.
normal. So in this situation, what would be the answer? Not check the patient, right? But rather continue to monitor because this is an
Expected finding.
finding. Continue to monitor and what? Document or something.
Bless you.
Okay, that's how they're gonna ask you the question on this. They'll give you a situation wherein there might be a problem and you have to understand if there is a problem or not. Because if there is a problem, if there's an option, check the patient first. If there's no option, then check the device. But if the scenario is normal, then what answer do you pick? Continue to monitor and just document. Because it is what? Expected. Okay, that's the type of question that they'll be asking you on this. Okay? Is that clear, guys?
Mm-hmm.
So here's another example. The nurse is caring for a client who has pneumothorax and the water seal chest tube drainage system to suction. Which of the following actions should the nurse take?
B. Below the chest.
What would you do for in this situation? There's really no problem, but you just have to what?
Maintain the drainage
container below the level of the chest.
Chest.
Okay, why? Why do we have to keep it below the level of the chest?
So
you
no,
don't want
yeah, to
whatever
come
is
back.
draining to reflux back.
Yeah.
Okay? there's really no problem in the actual scenario. It's just asking you how do you maintain the integrity of the chest tube. What do you do? Keep the container below the level of the chest. Okay. Alright, very good. Here's another one. The nurse is caring for a client who has a 3-chamber closed chest tube system. Which of the following should the nurse do after noticing a rise in the water seal with the client's inspiration?
Inspiration. Contain the monitor. What's the title? Huh? Suspenseful. Dramatic pause. Contain the monitor. Huh?
What do you think is the answer, guys?
A.
The answer is
A.
continue to monitor
Yep.
the client. Okay, so just a reminder, the system, which is the water seal, the center system,
It titles.
that's the term. I heard it. What was the term?
Titles.
Idle. Nice, very good. That's what actually they use on the exam. So the center chamber right here, this is the water seal. So the water seal, it's consistent that it actually has a height of 2 centimeters. And the type of water that you put here is what? Sterile. Okay, it's sterile. Right? And the other thing that you monitor on this, other than maintaining a height of 2 centimeters, is you want to see the water what? Going up and down. Or the term is
Titling.
tidally, or the other term that they use is fluctuating. Fluctuating.
I like title because it reminds me of the
So when
sea.
it's tidling, that's what? That's a normal finding, so you don't really have to do anything. Okay, now, let's say for example, let's say I remove this, right? Let's say I remove this. Right, and I put that. What do you think would be the answer? Because that's the only
Reposition.
possible thing. Reposition the client and check the chamber. Right? Because if the rise and fall stops, it can be either a good thing or a bad thing. Why a good thing? Good thing is maybe because the lungs have already what?
Re-expanded.
Expanded. That's why it stopped. That's why it stopped tidally. Right? The lungs have already expanded. How do you know that though? Other than using a chest x-ray, how do you know if the lungs have expanded?
There's no more titling.
By doing what? By doing what? Auscultation
Oh,
of
the lungs.
lung sound. Why? Patient that has pneumo or pneumothorax on the affected side of the lung has what?
Absent.
Absent lung sound. So if the lung sound has come back, then that tells you that the lungs have already what? Expanded. And that's a good thing. That's why it stopped tidally. But you still have to what? Check the patient to make sure that it has actually what? Expanded. The other thing, okay? Hear this. Other than the lungs have expanded, the bad thing, it's probably what? Kinked. The line is kinked, and that's why you don't see what? Any idling. You have to check that. Okay, so that's not a normal finding. So it can be a good thing or a bad thing. So in that situation, you have to either check the patient or check the chamber. Right? Is that clear, guys?
Yes.
All right, very good. So here's a picture of the chest tube. Okay, and if you look at it, it's kept below the level of the chest. And this one are the three chambers. You have the collection chamber, you have the water seal, and then you have the suction chamber. Right? So remember, the collection chamber, you monitor the amount. You want to make sure that the amount here is no more than 70 ml per hour. You don't want to exceed that. Okay, maximum 70 ml per hour. If you get more than that, what do? You have to report that to the physician. Okay. So you monitor the amount here. Other than the amount, you also monitor the what? The character.
Okay, yeah.
Alright, the amount and character. Okay. The other one, other than the amount and the character, when you say character, whether it's sanguineous, whether it's serosanguineous, whether it's serous, or whether it's purulent. If this is sanguineous and purulent, what do? Report that immediately to the physician. If this is serosanguineous or serous, what do? Nothing. Continue to document. Right? Monitor, continue to document. Okay? Now, the waters, remember, you cannot empty this. So if this is close to like 2/3 full, you have to change the entire fluid bag. So it's important that on the question, because they're going to ask you what should you have on bedside, you should have what?
Extra.
A spare one, this
Okay.
one, okay, and a spare bottle of sterile water. Right? A spare bottle of sterile water. Third one, pressure gauze. So those are the three important things. Okay? One is another fluid bag. Number two is bottle of sterile water. And then the other one is pressure
Plus.
gauze. Okay, pressure gauze. Okay, so
Did you say 2/3 full?
2/3 full. You don't want to wait when it's full. You want to immediately empty, change it already once it's 2/3 full. Because what happens is if you get this to full level, it can spill to the other chamber. Okay, so as soon as we get close to 2/3 full, you have to change the entire system itself. Okay, so we have fluid bag, bottle of sterile water, pressure gauze. So water seal, what do we monitor? You monitor the height, it has to be 2 centimeters. You want to make sure that you're putting sterile water, and you actually get bubbling here, but not continuous bubbling. What you get is intermittent bubbling. So you should have intermittent bubbling, once in a while bubbling, and you want to make sure that the water is what? Tidally.
Okay, tidally.
So that's expected. A tidling water with intermittent bubbling, that's expected. What do? Nothing. Continue to monitor and document. Okay, continue to monitor and document. Right. Now, other than that, the water seal, the last one is the suction chamber. This one. What do you monitor? There has to be continuous bubbling. Continuous bubbling. Right? And other than the continuous bubbling, we monitor the height of the water. versus the suction order. Right? So what do I mean by that? And this is very important, class, okay? Because this is one of those that usually comes up when they ask. When you put the water in the suction chamber, the height of the water is only between 15 and 20 cm. That's the usual height. 15 to 20 cm. That's the usual height. Okay? That's the usual height. 15 to 20 cm. Okay. Now, the doctor will also give you an order to set the suction between 15 and 20 mmHg. Right? So, between the height of the water and the suction pressure, which one again was given by the doctor? The suction pressure. So, what does that mean? What does that mean? That suction pressure, there was an order written for it. So, you have to make sure that the height of the water follows the suction order. So, if the suction order is 16, what should be the height of the water? 16. Now, I have a question for you. This is what they usually ask. The height of the water is 15. The suction order is 19. What would you do as a nurse? You lower the suction order? You add water? Do you
Add
leave
water.
it as it is? What do you do?
Add water.
What? You add water. Because you cannot change
Steril.
the suction
Steril.
order. You can make changes to where? On the water. Because the water is not ordered by the physician. What is ordered by the physician? The suction. Is that clear, guys? Alright. So, the three equipment, why do we need it? Floribap, if something happens to this, you need to replace it, you need to have a what? A spare. Bottle of sterile water. If the connection, let's say this is the connection, right? Connected to the patient. If this connection gets dislodged here, it gets cut off here, and you don't have the Floribap, what you're supposed to do is put the end of this tube inside the bottle of the sterile water. Because that becomes a temporary water seal. That becomes a temporary water seal. Right? Now, pressure gauge, what is that for? If the connection actually gets cut from the patient, and can you put that back as a nurse? You can, the physician, right? So what do you do?
Pressure
You
gauge.
put the pressure gauge on the patient, but you only take 3 sides. Okay? You only take 3 sides. Why 3 sides? Because the side that's open becomes a what? A pressure release valve. It actually allows the air to come out, but doesn't allow air to come back in. Okay? Alright, we clear? We're gonna go on a break, but before we go on a break, I already have an answer for your restraint. So, we got thyroid topics, hypo and hyperthyroidism. Right, so those are the things that might come out depending on exit. Oh, wow. You saw that. This big team is Ghostbuster right now. Wow, okay. Go. Yeah, so thyroid hormones, right? So there are 3 main labs that you want to be checking for our thyroid disorder. It's a TSH, T4, and T3. So you want to make sure you guys are aware of the difference when it comes to lab values. When a patient is hypothyroid, they're hypo, what happens is you have elevated TSH, but low T3 and low T4. Okay, so that's hypothyroid. Elevated TSH, low T3, low T4. For hyperthyroid, you might have lower or normal TSH, but elevated T3 and elevated T4. Okay, so why did I say that? Because there's one question on our exit about levothyroxine or Synthroid. Okay, so levothyroxine or Synthroid is a medication for hypo or hyper?
Hypo.
Hypo, correct. So we all know that levothyroxine is a medication for hypo. So this is where it comes in. Levothyroxine over the other name is Synthroid.
Oh,
There you go. Levothyroxine or Synthroid. Right now, the question is, if a patient has hypothyroidism or Hashimoto's thyroiditis, and they're started on levothyroxine, how do you know if the medication is working? Okay, now, of course, a lot of times we depend on signs and
Manifestations.
symptoms.
Yep.
So that means that if the levothyroxine is working, that means their metabolism is increasing, and that's actually relieving a lot of the signs and symptoms of hypothyroidism. Like what? What are the different signs of hypothyroidism?
Low, yeah, weight
Weight
gain,
gain,
low BP,
what's that? Fatigue,
cold intolerance.
constipation,
Yeah.
right? Intolerance to cold, right? So the other one is low vital signs, meaning
Yeah,
low heart
BP,
rate, low
or, yeah.
respiratory rate, low blood pressure, low body temp. All of that is going to get better, right? Because of the levothyroxine. Now, other than that, the other thing they'll ask you is, among the three right here, which one is the determining factor of how they know if the medication is working? Don't forget, this is the one that they monitor the most,
TSH.
not the T3 or the T4. Because the T3 and the T4, that will follow because that's what the medication is already. That's T3 and T4. That's synthetic. So they know that's going to go up already. But what they want to go down is this. Okay, why? Because this is toxic. That's toxic. Alright, so, and plus, the level of TSH is more consistent than the level of T3 and T4 because the body keeps using T3 and T4 every day for our metabolic processes. So the level of that changes throughout the day, but not the TSH. The TSH is more consistent. So it's easier for them to monitor the therapeutic effect of levothyroxine. So what happens? From an elevated TSH, if the levothyroxine is working, then the TSH should go down and go back to normal. Right? So on the test, it will already give you the normal range. It's just up to you to pick which one would be the best answer for the therapeutic effect of levothyroxine. Okay, so if you don't get, if there's no option for it to be at the normal range, then pick an answer that it went down. That's the next best answer. Okay, so again, if there is no option for the TSH at normal range, then look for a TSH value that went down from the original level, and that's what? That's the best answer. But you don't also want to be what? Lower than normal. So don't pick an answer that's below what? 0.5. Okay? Right, so the answer that you can pick is either they're on the range or they are lower than 5. That's what you should pick. Don't pick something that is below 0.5. Don't pick something that is above 5. Is that clear, guys? And or depending on what the value they give you on the test. Okay? The normal range. Is that clear, guys? Alright, so as I mentioned, there is two types of thyroid disorders. We have hypothyroidism, right here, right? Other name, depending on how you see
Hashimoto's.
this, is also called Hashimoto's. Alright, so you see the name Hashimoto's, and it says Hashimoto's thyroiditis, that means they're talking about hypothyroidism. Okay, so hypothyroid patient, their metabolic rate is very slow. So if you think about it, they're usually low and slow. That's their value. Low and slow, except for one thing that goes up with hypothyroid patient, which is the weight, right? They gain weight. But everything else is low and slow. Low vital signs, they develop constipation, they're fatigued, they don't really have enough energy. Okay, they have cold intolerance, okay, menstrual irregularity, or it's very abnormal when it comes to menstrual cycle for women. Right, they do have muscle weakness, okay, hair loss, basically right there. Right. Now, for Hashimoto's, the worst thing, the severe form of hypothyroidism is what we call as edema, correct? Alright, which is the opposite of hyper, because with hyper, it's what we call as thyroid storm, right? Okay. So for hypo, we have mixed edema. We have mixed edema coma. That's the worst thing. That's when the patient has very low metabolism and they just end up going into coma. Right? So in that situation, it's important that once a patient has been diagnosed with hypothyroidism, they should be started on immediately thyroxine. Very good. It's a lot easier to manage and to treat hypothyroidism because all they need to do is take levothyroxine. That's it. Yeah, for life. That's right. That's right. And again, the other name is Synthol, right? Synthol. Okay, so the other thing. So once the patient starts taking it, that's actually a synthetic form of P4, primarily P4, which gets converted by the body to P3 so that the body's metabolism goes up. That's the purpose of this medication, to increase metabolism. Now, here's the thing. The medication needs to be taken early in the morning, and the reason for that is to prevent insomnia. Right? Because if they take it in the evening, their metabolic rate will go up in the evening and they won't be able to go to sleep. Right? So it's better taken early in the morning when they're busy, so they'll have enough energy throughout the day. Also take it on an empty stomach before meals. It's better taken before meals. Mixing it with food usually decreases the absorption of the medication. So you want to make sure that they're taking it before meals, or before breakfast, things like that. Okay? Early in the morning. The other one, it has to be taken for life. You can stop taking it. You have to take it for life. Now, other than that, once the patient starts taking this, you also need to monitor signs and symptoms of hypo and signs and symptoms of hyper. Plus, the doctor monitors the TSH. Because remember, if the medication is therapeutic, what happens to the elevated TSH? It should go back to normal, down,
or decreasing,
or normal, right? Remember? Right? And then, here's the thing. Why do they monitor hypo? If the patient is still hypo, and the TSH is still elevated, right?
Yeah, they need to increase the dose.
Is
too low.
Too low, right? Still hypo, dose is low. Not enough. Not reversing the problem. Correct. If though the TSH, right, immediately drops, we're less than
0.5.
0.5, and the patient now is hyperthyroid, then that means the dose is too high. Right? Which happens a lot more when a patient is immediately started because it's a hit and miss, when it comes to levothyroxine. They have kind of a protocol on what to start them. but sometimes it's too much for the patient. And what will you start to notice? They start having signs and symptoms of, instead of hypo, they start having hyper. Right? So if they start having signs and symptoms of hyper, the dose is too much. So that's why if you look at the picture right there, because that's one of the most important things to monitor once a patient is started on levothyroxine, the radial pulse. Okay, why? If the dose is not enough, and because the pulse is one of the things that changes immediately with the dose, what does it tell you? If the pulse of the patient is 55, what does it tell you about the dose? It's what? It's not enough. It's too low, right? The dose is not enough. The dose is low. But if the patient's pulse, radial pulse, is consistently at 120, 130, what does it tell you about the dose?
Too high.
It's too much. Right? The dose is too much. And that's why the patient has been consistently tachycardic. Dose is too much. So you want the patient to be, again, between 60 and 100 so that you know that the levothyroxine dose is what? Just enough. Okay? Just enough to maintain metabolism for the patient to go back to normal thyroid state. Now, you guys?
Yes.
And remember, once a patient goes into hyper, which is the opposite of hypo, right? All of these signs and symptoms, of course, reverses. Right? So, this is what happens. There you go, right? Now, everything becomes high and fast, except for one thing. What is one thing that goes down?
Weight.
Right? This one loses weight. Yeah. The TSH usually either low or normal. It can also become normal. But you will have, of course, elevated what? T3 and T4. Okay, now, the other thing that's also unique about hyperthyroid patients is that they actually have this exophthalmos, right?
Mm-hmm.
The hypothyroid patient don't have that. But hyper has exophthalmos or bulging eyes. So you want to make sure you're taking care of their eyes, right? You want to make sure it's protected and covered when they're sleeping. You want to use artificial tears, right? You want to make sure they're wearing sunglasses if they come out so the eyes doesn't dry up.
Fuck these fellas. Oh.
Right? But both of them, you know that mass on the neck, what is that called? Goiter.
Goiter.
Both of them though, whether hypo or hyper, they have goiter. Although it's more prominent in hyperthyroid patients. Now, for hyper, of course, the one that's going to be on our exit is the manifestation of thyroid storm. Right. So there's a triad, right, for thyroid storm. What's a triad? What are the three things that comes out of a thyroid storm?
Temperature, blood
High
pressure.
blood pressure, hypertension, right? What else? Severe tachycardia, right? Or severe, like, dysrhythmia, right? And then, of course, hyperthermia, elevated body temperature.
Mm-hmm.
They become severely hyperthermic, which is not good. It can kill a lot of the patient's cells. So that's why it's dangerous to go on a thyroid storm, and the patient has to be taken to the ICU immediately. So again, hypertension, tachycardia, hyperthermia. The usual problem, bless you, that can happen, especially if this happens during surgery, is they can bleed to death with a thyroid storm. Bleed to death. So that's why monitoring the patient's thyroid levels and making sure that it's normal before they go to surgery. Because it's very risky for them to develop a thyroid storm. So, what are the medications? So you have propylthiouracil or PTU. The other one is thimerosal. These are what? Anti-thyroid medication. Both medications are anti-thyroid, meaning it's supposed to stop the thyroid from producing thyroid hormone. So what they'll do is, They'll give that to the patient first. Okay?
Demonstrate.
They'll give that to the patient first and make sure that the thyroid hormone levels are normal, T3 and T4, before they take the patient into surgery. So that the patient doesn't develop what? A thyroid storm. Okay? So just be careful. This can cause also the patient to become hypothyroid. You don't want that. Plus, it's also a risk for, just very important, just in case this term comes out, a
Granulosa.
granulocytosis. Okay? A granulocytosis, it's the same term for neutropenia. That's what it is. Okay? So you see that a granulocytosis, think of what? Low white blood cells,
Yep.
which can make the patient at risk for
Infection.
So that's one of the adverse effects of this anti-thyroid medication. It can put your patient at risk for infection. Okay. So in this situation, monitor the patient closely for signs and symptoms of infection when they take methimazole or propylthiourate. Alright. Any questions? Right. Don't forget the signs and symptoms. They're gonna ask that for sure, okay, on our hyper and hypo. Take a look. The nurse is caring for an adult who is being evaluated for Graves' disease. Graves' disease is the other name for
Hyper.
Which finding is most likely to be present? Number 2, yes, a weight loss. Yeah, hyperthyroid patient, remember, they sweat a lot because they have heat intolerance.
Mhm.
They have diarrhea, right? They have a lot of anxiety and tremors, okay? And then their vital signs are all what? Elevated. Elevated vital signs. Then, of course, they have that exophthalmos. So we discussed about the medication, okay? And here are some of the prioritization of care, especially providing a cool, calm environment for someone who has hyperthyroidism. Just remember, they're very stimulated and you want to avoid overstimulating the mind. Alright. So really quick, want to go over this one. The main focus though on this is airway. Okay. So one of the things that they will ask is what would be an important equipment that the patient should have at bedside
Trachea.
after a thyroidectomy.
Trachea.
What's that?
Trachea.
Correct. Very good. Correct. A tracheostomy kit. So tracheostomy kit, suction equipment with the suction machine and catheter, oxygen, that's what you need. But the most important one is the tracheostomy kit.
That's it.
Excuse me. The tracheostomy kit, right? Why? Because after the surgery, the patient's neck can really swell up.
The airway.
So this area of the neck, can easily swell up. And when that becomes swollen, it can actually constrict the airway. So it's important that we assess the patient's what? Airway and breathing. Check for any wheezing or stridor. That's an emergency, right? Wheezing or stridor is an emergency situation. Why? Wheezing and stridors are the type of lung sound that tells you that the airway is constricted, right? It's narrow. So you have high pitch, wheezing, or stridors. You have to report that immediately and make sure you evaluate the client. Okay. The other thing, check this for, of course, severe swelling or inflammation. Right? Because again, that can constrict the airway. Now, other than that, of course, you monitor that area for bleeding. That's the next thing. You want to check the front, you want to check the back of the neck, right? Or the back of the patient, and sometimes the blood can drip to the backside. You can see it. So again, airway, breathing, and circulation. Okay. Now, other than that, one of the other complications that I just want you guys to remember is Chebostex and Trousseau's. Okay. Yes, very good. Hypocalcemic tetany. Okay, so patient after a thyroidectomy, when they surgically remove the thyroid, the parathyroid gland is immediately behind the thyroid. So the parathyroid can be damaged, and when the parathyroid gland is damaged, what happens is it lowers blood calcium level. The patient becomes what? Hypocalcemic. So they become hypocalcemic, right? So their blood calcium drops, and the problem though is when the blood calcium drops, it actually causes their nerves to be very excited, which can cause tetany or seizures. So that's why it's important that after a thyroidectomy, we need to check their serum calcium level, right? So check serum calcium level. And other than checking their serum calcium, that we want it to be at 8.5 to 10, right? Other than checking that, we also could use the Trousseau's and Chebostex. So the way you do a Trousseau's is you put a blood pressure cup here, and then you watch their fingers. If their fingers closes like that when you inflate the cup, that's a positive Trousseau's. That's a problem. That could mean that they're what? Hypocalcemic. The other one is the Chebostex. Chebostex is you tap on the facial nerve right here. You tap on it, and then you'll see their lips or their jaw twitch. That's also a sign of hypocalcemia, positive Chebostex. That's also what? A risk for tetany. Okay. So what's the antidote? What is it? IV calcium gluconate. Very good. That one, right here. IV calcium gluconate is the antidote. So we can immediately bring up their serum calcium levels so that they don't develop tetany or seizure. Okay? Don't forget that, guys, for thyroidectomy. Okay? Question?
Calcium gluconate.
Alright, so here's another thing I want you to remember. Extreme hoarseness or inability of the patient to talk. That means they're also what? Short of breath. And that could be what? Airway constriction. That's also what? A priority, because that means that the neck is probably swollen, and that's why they can't even talk straight. They're short of breath. Okay, so that's another priority, because you're probably going to need an artificial airway. Okay. Alright, very good, guys. We went over traction, bugs, skin traction. Alright, the next one. They're going to ask you on classification and therapeutic effect of chemotherapy. Okay. So therapeutic effect of chemotherapy and carcinoma. So before we go to the actual positive effect of chemo, one thing that they want you guys to know is the staging of cancer. How do you stage carcinoma? Okay, so there is a system called the TNM system. Don't forget this. Okay? The TNM system is actually a system where they try to look at the tumor, the amount of lymph nodes that's involved, and possible metastasis. Okay, so that's the three things they look at. Don't forget that, because that's, I think, what they're going to ask. What are the assessment or tests that they do to determine the stage of carcinoma? So again, it's on the tumor, the amount of lymph node that's involved, and the amount of metastasis. So when you say metastasis, what does that mean? Spread, right? That from an original location, it went somewhere else. So let's say, someone has lung cancer, but it actually started as a prostate. That's metastasis. Okay? So it's a TNM system. So again, they look at the tumor, the node, and the metastasis. Okay, so don't forget that. So here are the different stages. Okay, and of course the last stage is when the cancer is metastatic. Okay, so just don't forget those three things that they categorize. Alright, now, other than surgery, as I mentioned, one of the important effects or treatment for cancer is chemotherapy, right? Okay. So there's a clue on how you're actually going to answer that question. Chemo. Because the question is, how do you know if the chemo is having a positive effect? Think of the negative effect of chemo and make sure that you pick an answer that it's not there. Okay? Let me give you an example. Give me one negative effect of chemo.
Nausea.
Alopecia.
Yeah, alopecia.
Right? So, how do you know that it's actually having a positive effect? That the patient is able to maintain their hair. They're not losing. Okay. One example that usually comes out on our exit is on their ability to eat. Okay, why? There are two things that you will see that's related to this topic, that's related to eating. Number one is nausea and vomiting, right? They have severe episodes of nausea and vomiting. The other one that's related to this that they ask on our exit is stomatitis. That's the other one. Okay, so chemotherapy, because it actually disturbs your stomach, the patient is the tendencies, they always get sick, right? Especially after chemotherapy. They don't have the appetite, it produces so much acid, so they have the tendency to become nauseous and vomit. So in this situation, what would be something that's positive brought about by chemo, that the patient is able to eat? Right? Or, even though they're using antiemetic, which we usually give when? Zofran, right? Before they eat, that they're able to eat their meals. Or they're not losing what? Weights. That's important, right? The other one is that another contributing factor to that problem is stomatitis. What's stomatitis? Chemotherapy has an adverse effect of causing sores
in the mouth.
Okay, sores. Sores develops in their mouths because of the damage to the mucosa. So here's the thing. Positive effect of chemotherapy, they don't develop sores, and then the same thing, they're able to eat and not lose weight. Okay. Not lose weight. Is that clear, guys? Okay. The other thing, hopefully this might be the other one that they might ask, is that chemotherapy, the bad effect also causes anemia, thrombocytopenia, and actually what? Neutropenia. Yeah. That's the danger of chemotherapy. It actually suppresses your bone marrow. So when it suppresses your bone marrow, your red blood cell drops, your platelet drops, your white blood cell drops with it. Okay, so what's a positive effect? Make sure that they're what? The hemoglobin and hematocrit is normal, platelet is normal, or they don't have any signs and symptoms of
Bleeding.
platelet,
Yeah.
bleeding, right? And their white blood cells is normal, or they don't have any signs and symptoms of infection. That's what they'll ask. Okay, so remember that because you will be asking about positive. How do you know if the chemo has positive effect? By remembering the negative and what? Reverse. Okay, is that clear, guys?
Yes.
Very good. Okay. Go now to our next topic, which is myocardial infarction. So we have two heart conditions, and both of them, other than multiple choice, they're NGNs. There's two, MI and heart failure. Okay? Those are the two heart conditions that's going to be on our regular question and NGN. So first is myocardial infarction or MI. Okay. So how do you know what's the difference between an MI and a regular angina pectoris? So a regular angina, you get a regular chest pain when you're actually putting a lot of effort, a lot of physical activity. But then, as soon as you start sitting down or resting, what happens to the chest pain? It goes away, or it gets better, and it's taken care of by what? Nitroglycerin. Right? Nitroglycerin is able to take care of the problem. But for a myocardial infarction, the chest pain can be what? All of a sudden, even if you're not doing anything, even if you're just sitting down watching TV, you can suddenly have a severe chest pain that radiates. That's the thing about a true MI. It radiates, meaning it goes on different locations. The jaw, the neck, the shoulder, the back. In females, they also develop, abdominal or epigastric pain. Okay, so it moves. When it comes to myocardial infarction, and even if they rest, does the pain get better? No. If they're given nitro, does the pain get better? No. Right now, other than that, lab test. What is the most accurate lab test for MI? Very good. Okay. Troponin. Okay. Now, if you don't have troponin, the next best answer is CPK. Or the other one is ESR, erythrocyte sedimentation rates. Okay, so again, if you don't have troponin on our exit, look for either CPK, creatine phosphokinase, or ESR, erythrocyte sedimentation rate. Okay, remember, for someone who's having an MI, if they give you the normal value of troponin on your test, troponin should be down or elevated? Elevated. That's an MI. An MI is equal to elevation of troponin. And troponin can stay elevated for weeks. That's the nice thing about troponin. You will really know if the patient had some kind of MI. Okay, is that clear, guys? Okay, the next thing. They'll be asking you this. Other than troponin, the next best thing to identify if the patient is having an MI is through EKG. Right? Now, your normal EKG reading is like this, right? Right? There you go. You have your Q, R, S,
T,
P, Q, R, S, T, P, Q, R, S, T. Right? P, Q, R, S, T, P, Q, R, S, T, right? You have your Q, R, S wave followed by the P and the T. That's normal. But for someone who's having an MI, tell me what this is.
elevated T waves. ST elevation. ST elevation?
What's the difference?
No
That's an
problem.
MI right there. There's a type of MI at the bottom.
STEMI?
What's that? I heard the term.
STEMI.
STEMI. So a STEMI MI, it's called STEMI because the S and the T segment is what? Elevated.
Elevated.
Okay. So what you want to remember is that if you have an MI, especially if it's STEMI, one of the best way to recognize it through EKG is you have an elevation of the ST segment. Now the question is, can you have an MI without an ST segment elevation?
Yes.
Yes, you can. Your patient can. That's what we call as a non-STEMI. But for a non-STEMI, they will also have what? An elevated troponin. Okay? But the ST segment is not elevated. So for a STEMI, you will see a what? An elevation of troponin and an elevation of the
ST segment.
But for a non-STEMI, you will only see an elevation of troponin. Okay, is that clear, guys? Okay, all right. So, very important because this might come up. When you're doing an EKG, what is the best way to position the client?
Supine?
Left side.
Oh.
Okay, left side. Although the next best option is supine with the head of bed elevated. But the next best, the best one though, the best answer is left side lying. Okay, for your EKG.
Or supine.
Okay. So, other than that, once the patient has been identified as having an actual myocardial infarction because of the troponin and the ECG wave, then what's gonna happen? They'll immediately give
Oh no.
Mona. Right? Okay. So you want to give Mona because if you don't, this is actually what happens, you know.
Oh. AFib? Oh. Asystole?
That's what happens, right? That's what happens if you don't give Mona. But from your ST segment, you go on ventricular tachycardia.
Yeah.
This is ventricular tachycardia. Then you go to ventricular fibrillation. Then you go
Asystole.
That's it. Yeah. That's it. Flatline. Right? Flatline. Okay. You guys see the movie Flatline? That's impressive. They kill each other to bring themselves back. You guys see that? Because they want to see
Gonna watch it now.
next slide. Don't do that, okay?
Yes.
But it was called Flatliners. It's a good movie. It's a good movie. You should watch it. So, but yeah, you don't give the Mona, your patient goes into ventricular tachy, ventricular fib, and then asystole or flatline. So, what do? Give the Mona, right? Yeah, because they come really altered. Because what they do is they give the medication to stop the heart, and then they shock them to bring the blood. Crazy, yeah. So, but yeah, you give the Mona, right? Which one is the first one you give?
Oxygen.
So don't just forget that, okay? Because on your NGN, they will ask you on plan of care. Right? So it's a select all that apply plan of care. Alright? Select all that apply plan of care. So what's the plan of care? Mona. Give the oxygen, you give the nitro, the
Morphine and the aspirin.
aspirin. Alright, before they go asystole or flatline. Okay. Don't forget. Any question on MI? Now the other plan of care. MI patient can be started on, don't forget, write this down, okay? Because they might ask this as part of the select all the apply. They can be given thrombolytics. Thrombolytics are medication that actually breaks down clots. Okay, so you have alta place, and the other one is streptokinase. So if you see the name alta place and the other one is streptokinase, you know they're medications that can break down clots. Medication that can break down clots. It has to be given though, for a stroke patient, it has to be given within the first 3 hours. For an MI patient, it has to be given the first 4 hours because it loses effectiveness. The longer you wait to give the med, it's not going to work anymore. Okay, what's the purpose of the med? To break down the clot so that blood can flow back into the heart. So that the heart can get its own blood, right? Alright. So, other than thrombolytics, the patient will also receive anticoagulants, okay, as part of their treatment. Usually, they will start the patient on heparin, and then later on be brought down to Coumadin. Coumadin, for warfarin. Okay.
That's warfarin and heparin.
And then the patient can be placed on long-term or for life. What was that medication? Plavix. Clopidogrel. We talked about that, right? As part of our medication on our exit. Plavix. It's an anti-platelet. Okay, so from a thrombolytic, they will be downgraded to an anticoagulant, and then from an anticoagulant, they'll be downgraded to an antiplatelet, which is Plavix or clopidogrel. Okay. Other than that, lifestyle changes. What kind of lifestyle changes?
Heart healthy diet.
Right, at least 15 minutes a day,
Okay.
and staying away from
Fats.
cholesterol.
Yeah,
minimum,
cholesterol.
minimum, at least 15 minutes a day. Minimum.
Is
That's
15
just
minutes?
minimum. Of course, that would be a referral also for a physical therapist. And of course, stay away from food that is high in
Fat and cholesterol.
Right, glycerol. Right. Okay. Avoid smoking and drinking alcohol.
Exercise.
Any question on the plan of care? Don't forget, that's the question. It's going to be plan of care. Okay, other than
Drinking.
identifying an MI.
Cholesterol.
Everyone got this? Yes?
Plan of care.
Alright, next, heart failure. Okay, then we'll go on our kind of take a lunch break. Just for a little bit. Okay, heart failure. We have 2 heart failures, right? Right-sided and
Left-sided.
left-sided. Okay, so that's what they're gonna ask. One of the first initial on our NGN on this is Q's. Very straightforward though. It's probably just gonna ask the sciences. So, left-sided and right-sided. Okay, so JVD. Left or right? Right. JVD is right? Ascites. Ascites. Right. Ascites is fluid in the abdomen. Alright, so pink prod is sputum. Left. Very good. Crackles in the lung.
Left.
Left. Orthopnea.
Left.
Hepatomegaly. Right.
Right.
That's an enlarged liver, right? So outside the lungs. So if it's outside the lungs, it's not related to the lungs. Guess what? That's an easy right. Right? Don't pick
Ano yung JVD ulit?
things that are related
Right.
to the lungs, like shortness of breath, crackles,
Okay, got it.
pink frothy sputum. Okay, because those are all what? Left side. Left for lungs, R for the rest of the body. Right? Very easy, right? So don't forget our main medication for heart failure, digoxin. Right? We already talked about that. Any question though on digoxin? It's part of our farm. Everyone still remembers this, right?
Yeah.
Pretty much, if you look at here, tells you kind of like
Left
what
side.
do you call this? The signs and symptoms. Okay, so the other one, I'm not sure if I already talked about it, but I'm just gonna repeat myself. There's a question on this based on the use of Lasix. Remember what I told you? Lasix, don't pick an answer that it's increasing urine output. If it asks you about the therapeutic effect of Lasix, you have to base it on the benefit that the patient gets from it. So let's say, for example, right, the patient here is given Lasix. When someone who has left-sided heart failure, right, they're given Lasix or furosemide. If there is A, an option to increase urine output, and then B, there is the absence of crackles in their lungs, what would have been the best answer?
Crackles.
The absence of crackles in their lungs, not the increase in urine output. Because it's asking you for therapeutic effect, meaning what is the benefit that the patient gets from it. And now how about for a right-sided? Increase in urine output, what do you think would be a benefit of a patient from a right-sided heart failure from Lasix? Decrease edema, decrease ascites, absent JVD, right? Those things, okay? So that's the question, okay? So remember, it's not how the medication works, but what is the benefit that the patient gets from it, okay? So just in case that one comes out. Very good. Also, don't forget, for heart failure patient, one of the important things to remember, this is patient who have fluid overload. This is not dehydration. They have fluid overload, which means that part of their care is to what? Limit fluid intake, not to encourage it. Okay, because sometimes when that question on plan of care comes out, students misses that a lot, and they will pick encourage fluid intake because it sounds good, right? That's what we did always, like mentioned to us in class. You have to encourage a patient's fluid intake. Not for this one. This one, you actually what? Limit fluid intake. Same as someone who has what? Renal failure. Have renal failure, you want to make sure that they what? Limit fluid intake. Okay, now, there is one renal failure topic that's going to be on our exit, other than, and that is what we call as polycystic kidney disease. Have you guys heard about this condition?
Yes.
Polycystic kidney disease, there's no cure, right? It is a genetic abnormality wherein the kidney actually develops a lot of fluid-filled cysts, making the kidney grow as big as a football. Yeah, you guys seen one? Yeah, it's mind-boggling. Look at that. Oh.
That's disgusting.
There's no cure. The end result is renal failure. That's what it is. End result is renal failure. So what is the best way to manage this when we know that there's no cure? Delay the progression of the renal failure. So you want to take care of the kidney as much as possible. So take note. One of the things that they ask you is how do you determine the manifestation of the polycystic kidney disease and renal failure? Okay. Other than other than the problem with the increased kidney size, and also a PUN and creatinine of what? What do you think would be this patient's PUN?
High?
Greater than
20.
With a creatinine greater than 1.2. Very good. The other thing is, of course, urine output. What do you think would be the urine output of this patient? Decrease, right? Oliguria before it becomes anuria. Okay, so don't forget, other than checking the BUN and creatinine, it's important that we monitor
Less
this
than
patient's
1.1.
urine output.
Less than 1.1.
Because if the urine output starts to decrease, that's the number one sign of what? Renal failure. Okay? So don't forget that, because that's what they're going to ask. How do you monitor this type of illness? Okay? So you want to preserve as much as possible the function of the kidney and monitor for possible signs of renal failure. So again, elevated BUN, elevated creatinine, and decreased urine output. And the patient will have problem, of course, with
Greater
fluid
than.
deficit or overload. Overload. Patient with renal failure develops fluid overload problems. Okay, that's why, when they go to dialysis, right? The benefit of dialysis is removing excess fluid, removing the toxins, and balancing electrolytes, right? That's the purpose of dialysis. They remove the fluid, they remove the toxin, they balance out the electrolytes. Right? There you go.
Yay.
So we'll start OB in about 15 minutes, okay? And,
Okay, let's put her. Okay.
I don't know. She's like, I want to ask her. Doesn't seem to make sense. I need to do that.
welcome back, guys. Maternal. I'm sure we're not gonna need that much time here. I just need to pray. Good. I know. Okay. Alright, so let's start. Here are some of the things might come out. First is the maternal assessment, antepartum assessment. So don't forget your stages of pregnancy. There are three main stages: antepartum, intrapartum, and then postpartum. Antepartum is the main pregnancy itself, right? That lasts for about 9 months. In the stage of pregnancy, antepartum, it has 3 trimesters, right? So the first 20 weeks of gestation, your baby is not really viable yet. So any baby that's born less than 20 weeks is considered an abortion. Because most likely, of course, that baby is not going to survive. So babies that comes out less than 20 weeks, then it's already considered an abortion by the constitution. Now, for a baby that comes out at 20 weeks to 36 weeks, that's what we call preterm babies, meaning that they actually came out a little bit earlier, than they should. So 20 weeks to 36 weeks would be preterm. 37 weeks to 40 weeks would be term. And babies that comes out greater than 40 weeks would be post-term, right? For a child already, right? So yeah, you have a toddler coming out, right? That would be a disaster. That's dramatic. Oh man. Alright, so that's an important information in regards to the GP valve. GP valve, each letter stands for a specific meaning. G means gravida, which means the number of pregnancy. So when you see the term gravida, what that means is the number of pregnancies. So null or nulli gravida means never been pregnant, right? So multi-gravida means multiple pregnancies. And then, of course, preemie gravida means first time being pregnant. Right? Now the next term is para. So you have para means the number of deliveries. Okay, so again, as I mentioned, delivery can happen preterm, term, and post-term. Okay, so preterm, as I mentioned, would be from 20 weeks to 36. Term would be from 37 to 40, and post would be greater than 40. Okay. So that's pretty much, para, or the number of deliveries. Now, very important though, one thing you gotta remember, one exemption to the rule is when a woman delivers twins, they only count it as one delivery.
Sorry.
Okay? So let's say, for example, they delivered twins, 2 babies came out, but they only counted as one delivery. So it's not counted as 2. Alright, so if they say you have a woman that gave birth to twins 2 years ago, right? So let's say this is our thing. Woman gave birth to twins 2 years ago at 38 weeks gestation. Right? So that's the situation. That's what the exit gave you. A woman gave birth to twins 2 years ago at 38 weeks gestation. What would be this woman's G?
1.
G would be 1. Right? What would be the woman's T? 1.
Wow.
It would be
Wait.
1.
1.
What would be the woman's P?
0.
What would be the abortion?
0.
0. What would be the living?
2.
2. Very good. So they're counted as 2 living, of course, human beings, but they're only counted as 1 delivery. Now the question is, why P1? Because the delivery came at what? 38 weeks, which is considered term. So that's what the P stands for here, term para. The P stands for preterm para. A stands for abortion. So abortion can be elected abortion, like the woman decide on it. So yes, that would be counted in abortion. Or if the baby was delivered less than
20 weeks.
20 weeks. Yes, the baby was delivered less than 20 weeks, then of course that will be considered an abortion. And then L is the number of living
Children.
right?
Yeah.
So how many of the babies that were delivered several years ago are living? So that's what you count. So in this situation, it's a twin, so that means you have 2 babies, so that means 2 L's. Okay? Alright, very good. So let's take a look at this and let me know what's your answer.
Gave birth to twins at 36.
Read it.
Okay.
You guys can finish and answer.
Okay, so 3. Term is 1 P
Okay, so
0
let's take a look. Let's
A is
answer it,
1
right?
and L is 2.
So what's the woman's G?
3 she's
She
got
is
3
correct. It's 3.
Currently
Because the
pregnant.
woman is pregnant right now, pregnant 3 years ago, and pregnant a year ago, right? So
Yes.
because she's on her first trimester health appointment, so that means she's pregnant right now. She's pregnant 3 times, right? All right. So how many P's? 1 P. How many P?
0
How many P?
wait on 1 0 no 0 no
How many P?
is it 1 or 0
0.
Wait, what's the name? That's
that's an abortion less than 20 it's an abortion
Alright. So that's less than 20 weeks, 19 weeks. How
1
many? 1. And how many living?
2
Good job. There you go, guys. Okay. So preterm is only considered preterm if the baby came out at
20 to 36
20 to 36. Okay. So less than 20,
abortion
automatic. Because the thing is, babies that are born less than 20 weeks, they're less likely to survive because they don't have a functioning lung. Lungs usually
Maturity,
develops more towards 20 weeks and more. That's why when you have a high-risk woman, one of the things they do is they do an LS ratio. Your sphingomyelin lecithin ratio. That's what they do. That's for lung test. Okay, and that's why you will see some women, if they cannot stop the preterm labor, they will inject the woman with dexamethasone or betamethasone. What's the steroid for? What's the steroid that they use?
lung surfactant
To develop the baby's lungs faster.
Oh.
So that even though the baby comes out earlier, right, they can have a chance for a developed lung by injecting that steroid. Okay? So don't forget that. Right? Very good. Alright, so there you go. There's the explanation again of our GP valve. So don't forget our GP valve calculation. Okay? Any
beta
question? Here's another sample. A nurse is obtaining obstetric history from a client who's pregnant. The client tells the nurse that she gave birth to twins, 36 weeks gestation, and had a stillbirth at 24 weeks. The client also starts that she reports that she experienced spontaneous abortion at 12 weeks. How would the nurse document the pregnancy? Number 3. And para 2. That's good. Para 2. Okay. So how come it's gravida 4? What are the 4 pregnancy? Pregnant right now, right?
the
Pregnant with
twins
twins, pregnant with
stillbirth,
stillbirth,
and
and
the
abortion.
abortion. And then you have
Gravida 4, para 2.
yeah
Okay, which are the 2 paras? The 36
twins.
twins and the 24 week stillbirth. Because that's still considered the what? A delivery. But the delivery is just what? Stillbirth, not a lot. Right? Because that's 24 weeks, remember? That's considered preterm. You good? Any question? Next one, they're gonna ask you signs of pregnancy. Please don't forget. You don't really have to remember this, but it's a good idea to at least remember a few. The one that they really ask are these. So just don't forget Hagar sign, Gödel, Chadwick, and Balaknet. Okay, perhaps the mix, they all fall under probable signs. Okay, so if they ever ask, what is a Hagar, what is a Gödel, what is a Chadwick, what is a Balaknet, what is Braxton, what's a positive pregnancy test, they're all probable signs of pregnancy. So a Hagar is when their uterus starts to soften. Caudal is when the cervix starts to become soft. And then shadowing is when the cervix changes in color. It becomes a little bit purplish. Okay, or violet in color because of the increase in vascularity. Allotment is when the doctor does a vaginal check. The doctor taps on the cervix. The baby tends to float a little bit. The doctor feels that. And then, of course, the pregnancy test. The pregnancy test is only probable. You're probably wondering why. Because certain condition can also result into a pregnancy test. Like, have you guys heard in your OB the term hydatidiform mole?
Oh, yeah.
Hydatidiform. So, positive pregnancy test, uterus getting bigger, but absent heart rate. Hagar is the softening of the uterus. Yes. Ballockment is when this one, the doctor taps on the cervix and the baby kind of like floats.
Bless you.
But just remember, right? Any kind of vaginal bleed during pregnancy, should we do a vaginal check? We shouldn't, right? That's contraindicated. So always remember that for any kind of vaginal bleed, we are not supposed to do vaginal assessment. We can do an ultrasound, CT scan, to verify what's the cause, but avoid vaginal assessment as much as you can. Because it could be a brachioplacenta or a placenta previa. Might cause a problem.
Pregnancy.
Alright, are we good with this? Alright, and what are the positive signs of pregnancy? You really know they're pregnant? Well, you have the heart rate, right? That's an alien, right? That's an alien. Right? And then the other one is active movement of the baby. You see the actual baby moving. And then, of course, ultrasound. Okay, very good. Now, very important, there are actually two types of pregnancy tests that they'll ask you on the exit, and that is amniocentesis and ultrasound.
Amniocentesis.
Okay, amniocentesis and ultrasound. All right. So for an amniocentesis, that is usually done for high-risk mothers, right? When you think of high-risk mothers, what's the usual consideration? Age. Right? Age. Advanced age. You know, they're later than 40, so towards the end of their 40s, right? Advanced age. So other than advanced age, family history of genetic disorders. Another one. Things to remember. If the amniocentesis is to be done, or the ultrasound also is to be done less than 20 weeks, full bladder. Okay, that is needed for both. If it's less than 20 weeks when it's going to be done, they need to make sure that there's a full bladder. Why? It creates a better image. The uterus is too low, they want to lift it up a little bit, you know, if it's done less than 20 weeks, so they will ask the woman to have a full bladder. Now, if the test is done, amniocentesis or ultrasound is done after 20 weeks, M. Okay. The next one, I'm going to show you a quick picture of amniocentesis. It's one of those really risky diagnostic tests. So they won't really do this unless there is a real cause to do it, and the risk the benefit outweighs the risk. So if you look at this, amniocentesis is done by actually using a really long needle going through the woman's abdominal cavity and into the uterus, puncturing the uterus and collecting what? Amniotic fluid.
What else?
Genetic studies, possible risk, whether it's genetic or it's high risk pregnancy, things like that. And the needle is guided by an ultrasound. It's high risk because of the possibility of what? Amniotic fluid leak. The amniotic fluid might start leaking, it's not going to stop. And when the amniotic continues to leak, it can actually cause preterm labor contractions. And if that doesn't stop, then guess what? Get ready for a delivery. Okay, get ready for a delivery. Right now, because of the risk, because there's a needle going in, there's a possibility that the baby can get punctured and the baby's blood can leak, mixing with the mom's blood, resulting into
Hemolysis?
C, or disseminated intravascular coagulation that can also have the complication, remember, of L.
Okay.
Now, so when a woman develops DIC, because of that reaction between each other's blood and they go to health, the biggest problem here is bleeding. Right? They lose a lot of blood through hemolysis. That also results into elevated liver enzymes and low platelet, resulting into severe hemorrhaging. Okay, now, one of the things they'll ask you on the health is, how do you verify health? What is it that you check?
Enzymes?
So for the elevated liver enzyme, it's the ALT and the AST. They'll give you the range. Just make sure that based on the range they give you, you look for elevated. Look for a value based on the range they gave you that's elevated. So let's say they gave you a range of 40 to 60. Then look for an AST and ALT value of greater than 60. Because AST and ALT is what? Elevated at liver damage. So it is, okay? The other thing, low platelet. So you check for the platelet count. The platelet that you're looking for is something lower than 150,000. Right? So look for a count that is less than 150,000. And then hemolysis is you either look for low red blood cell or low hemoglobin and hematocrit. That's what you look for hemolysis. You look for a value of the red blood cell that is low. You look for a value of the hemoglobin hematocrit that is low. Okay, based on the range that they give you on the test. So that's why when this comes out, it's kind of like a chart check. They'll give you a chart and they want you to check on the laboratory tabs. Read the result based on the blood test. And again, you look for what? Low red blood cell, low hemoglobin, low hematocrit, elevated AST and elevated ALT, and low platelets. Okay, and then again, what is the priority to stop the woman from
bleeding?
Okay. Now, as I mentioned, what would be the best way in the event that this woman actually, the baby gets punctured by the needle? How do we prevent DIC? They actually give the woman Rogan. Okay. So they actually give the woman Rogam, although we all know that Rogam is routine. They routinely give it at 28-week gestation and 72 hours postpartum, because Rogam is supposed to prevent the mother from forming antibodies. So it's usually given to a mom that is Rh negative that has a baby that is Rh positive. Yeah. So don't forget, okay, Rogam is given to Rh positive mom and Rh negative. RH negative mom and Rh positive baby. There you go. That's what it is. Rh negative mom, Rh positive baby. So here's the thing. When that is given, that actually prevents the reaction that can happen between the mom's blood and the baby's. So don't forget that. What's the way of preventing the DIC? Rogam. Okay, so don't forget that they give mothers Rogam in the event that they're going to do an amniocentesis. Okay. All right, now, yes,
Regardless if they're orange native.
they do give it now routine.
Oh,
Yeah, but you can do it.
preventative.
But they do give it routinely. Now, for the purpose of routinely giving it, the Rogam is not, the DIC is not really a problem for the first baby. It becomes a problem for the second baby. Because the first baby is just gonna come out, and then during that time when the mom is not pregnant, the mom can develop antibodies. When she gets pregnant again, her body will kill the next baby. That's what happens. So that's why each time, if you get a Rogam, each time the woman is pregnant, they're gonna get a Rogam each time. If they get a Rogam again at 28 weeks gestation, 72 hours 45, they get pregnant again, they're gonna get another Rogam again. But again, you can refuse. You can write it down. You can, no, I don't want a Rogam. But then you're putting yourself at risk. Alright, unless you did a genetic study, like in other countries, they have like fixed marriages. For fixed marriages, it's a requirement that both male and female gets a blood test first before they can get married. So that they know that they're blood compatible.
Interesting.
No, that's usually where they give it when the mom is Rh negative and the baby is Rh positive. But in situations that they're not able to determine that, they'll still give it because what? It's a precaution. There's really nothing to lose because Rogam, there's really very little if any adverse effect, and the benefit is, especially if you're not sure, then you already know you can prevent the DIC. Kind of like an auto prophylaxis kind of. Alright, so don't forget, they're given a Rogam. Okay? Alright, very good. Next one. So next one on our question, non-stress test. So very important. Another one that they're gonna ask. Just remember, non-stress test is non-invasive. This one doesn't really cause any problem for the baby. All that the mom needs to do is what? Relax. And they will actually count the number of heart rate within a 20-minute period. Okay? So they're saying that for a non-stress test wherein the mom just relaxes like that and then they put an actual stethoscope, then during the time of relaxation, within a period of 20 minutes, they will count if there is an increase in the heart rate of the baby with contractions. Okay, now, so it is considered reactive if increase in fetal heart rate by 15 beats per minute for 15 seconds with movement in the 20-minute period. Okay, so if the baby moves and the heart rate increase, that means it's considered reactive. Okay, so the way they'll ask you this on the exit, if this comes out on the other version, is they'll ask you that. How do you know if it's reactive? How do you know if it is non-reactive? One thing that I want you guys to remember. If the option on the non-stress test has positive and negative, guess what? You can already what? Eliminate that. Because positive and negative result is for what test?
Contraction stress test.
That makes it easy because you can easily eliminate what? Two options. You're not supposed to pick positive, non-assuring, negative, assuring, because that's a result based on what? Contractions. If it's asking you non-stress, right? Then your result should be either reactive or non-reactive. Okay, so you will only pick answers that whether it is reactive or non-reactive. So it is reactive if the heart rate increases with movement. And it is non-reactive if there is no increase. Does that mean there's a problem? No. They'll just do what? Further test. If the baby's just moving, not moving at all, what can you do, right? You don't want to wake the baby up.
Yeah, need to. Non-reactive.
So they'll just do further tests later on. But it doesn't really mean what? Anything. But, like I said, the result is reactive if there's an increase in heart rate, and non-reactive if there is no increase. Now, for a contraction, what they'll do is they'll hook up a mop to a machine and monitor the number of contractions and how the baby's heart rate reacts to it. Very important. Take note. It is considered positive or non-assuring if the baby's heart rate decreases with contraction and remains low after contraction. That's not good. That's not a good sign. Because a good sign is when the heart rate of the baby goes down with contraction, after the contraction, what should happen to the baby's heart rate?
Go back up.
It should go back up. Now, what's the normal heart rate of babies under the womb, inside the womb?
110.
120 to 160.
60.
Yes. We have a baseline though of 100. That's still okay. But the ideal is between 120 to
160.
160. Okay. So they're saying that for a contraction stress test, wherein the machine is picking up the contraction, when the uterus contracts, the baby's heart rate should go down from its baseline, and then after the contraction, the heart rate should go back up. Right? That's what's good. But if it's not good, like the positive, it's gonna remain what? Low. So positive is when it remains low. Now, non-reactive or meaning assuring or negative, that's the good one. Because as I explained, negative means what? Baby's heart rate goes down with contraction and then goes back up after. So between the two, which one is the ideal one, positive or negative?
Negative.
That's what we want. That's what. Okay, so the same thing, if on the exam is asking you about contraction stress test, then you can already eliminate the options that had what?
Reactive and
non-reactive. Because for your answer, you have to either pick positive or negative. Non-assuring or assuring.
Assuring.
So the best, or the one that is good, which is weird, right? The negative is the good one, and the positive is the bad one. Good. Okay. Are we clear on this? Any question? Any question at all? No. Okay. All right. Alright, give me 1 minute, guys. Looking for one more. Alright, the next one that they're gonna be asking you based on antepartum or pregnancy, discomforts of pregnancy. So, not really much to remember here. Just make sure that on the different trimesters, try to find out where does, like, nausea and vomiting or hyperemesis gravidarum comes out. Is it on the first and second, or is it in the second and third? How about urinary frequency? Where does it come in? First, second, right? So in this question, what do you think is the answer? It's letter A, right? Urinary urgency or frequency is part of your first trimester. So Very simple. That's what they're gonna ask you. Discomforts of pregnancy. Just make sure you find out where they come in, where they're there in the first, second, or third trimester. That's that clear, guys? Now, other than that, alright, how to manage some of the different discomforts. So, there are only a few that comes out, and I'll focus on that already. The first one is the hyperemesis gravidarum. What does hyperemesis gravidarum mean?
Vomiting one more.
About the morning. Correct. There you go. Hyperemesis gravidarum. Morning sickness. Severe nausea and vomiting, usually related to, of course, the high levels of estrogen and progesterone to maintain pregnancy. Okay, now before we go here, there's one question though that I want to discuss already because I might forget. There's a question on how to prevent pregnancy, and that is on the use of contraception. Okay, so very important. One of the things that they'll ask you is about cervical caps. Right? It's like the female condom, right? It's just that cervical caps, they're inside, right? You put it inside. The cervical cap is supposed to cover the opening of the cervix, right? Opening of the cervix. Cervical caps are good for up to 2 years. You know, you don't really have to keep changing them. The only time you need to change them though is if you lose weight, right? If you have some active pregnancy, because the shape and the size of your cervix will change, right? So you have to resize, right? And get a different size of the cervical cap. Very important though, when you're using it, you want to make sure that you insert it first, right? Because if you don't insert it, well, it doesn't work. Insert it first a few hours before coming in contact. And you want to make sure, take note, you have to use spermicidal jelly. Very important. Okay? Yeah, I'm going to ask you about that. So you have to use spermicidal jelly. You coat that there, right? You put that on the cervical cap. Yes, and you have to wait for about 6 to 8 hours after the intercourse before you actually what? Remove the cervical.
Use
So you have to leave it there.
spermicidal.
Don't forget to take it off because it can actually cause toxic shock syndrome. That's a toxic shock. Just like you know when you're using tampons. So be careful with the use of tampons and cervical.
Spermicidal jelly. Okay, got it.
All right. We good with that one? The next one, injectables and implants. So Depo-Provera and then implant Provera, right? They are very effective. The reason why they're very effective is you don't have to take them every day like what? Your regular pills, right? So if barrier method is not working for you, you know, don't think of, and you want to do something that's more effective, then you can either use pills or injection or implant. Okay, here's the thing though, very important, but they're gonna ask you on pills. If you miss a pill, can you double up on it the next day? Yes. Yeah. Don't forget that. That's an answer to the exam.
Double up
You can
if
double
missed.
up. That's next day though. Don't double up every day, okay? Don't double up every day. Just the next day. On the thing that you first missed, right? But not every day. Just on that day, the next day that you miss it, take a double dose, right? And use other barrier methods just to make sure. But you can't. Don't forget. And the way the pills work is because, you know, it's actually synthetic estrogen and progesterone. So it's tricking your body that you're already pregnant. So if the body thinks you're pregnant, well, guess what? You're not going to get pregnant anymore, right? The body thinks you're already pregnant. Okay. So you can double up the next day. The other one, most effective. Don't forget this. You're gonna ask this on the exit. The most effective is either
Yeah.
abstinent. Right. So, but that's not part of the option. So the option is either you have an implant or injection. So the implant or the injection is the best. Okay, why? There's actually better compliance on it because you don't have to take it every day. You can have it there for a year, 2 years. For depot, I think it's written every 3 months. That's right. You get a shot again every 3 months. So there's better compliance because you don't have to do it what? Every day. So again, if that question comes up on which would be the most effective one, it is what? Injection or implant. It's the same thing. It might be, you don't just remember depot. The next thing, last one that you need to remember, contraindications to contraception. Very important to know. Don't forget. History of clots. Forget that. Okay? Cardiovascular hypertension and clots is the best answer. Why? Your hormone pills, especially combination estrogen and progesterone, although not the pop pills. You guys know the pop pills, right? Progesterone only pills. Those are less risky, but less effective. But if you want the effective pill, estrogen and progesterone, it's contraindicated for hypertensive women or women with history of clots. Clots is the best answer. Why? Because it makes the blood thicker, so you end up forming more clots. Okay, so don't forget that. Contraindication to contraception, what's the answer again?
Blood clots.
Okay.
That one too.
The next, best option. But clot is the best answer. Okay?
No. The being too big is the patch not right because I figured because they have effects.
That and the other one that's not appropriate is the cap. It's just it can be like too loose. That's right. Was it more of a change in the
Okay,
weight?
which one? Because of her weight, which one is like would be oral contraception?
Oh, it was just oral contraception.
Options for like the BMI was high, which would be, I think
Oh, the question is what's contraceptive? What's contraindicated?
contraindicated for that hormone.
It's the clots. If you have the
But it was
cardiovascular.
6 to 12, so, yeah, so it would be the BMI because
You have other options. Ectopic pregnancy. Ectopic pregnancy is a pregnancy that happens not in the uterus, but it can happen in the fallopian tube, right? Or that can be one of it if you don't have the hypertension and the blood clots. If you guys remember it, then let's discuss it.
What?
Alright, okay, next. Going back. Hyperemesis gravidarum. How do we take care of this problem? So,
Rat diet?
number one, when they wake up, tell them to get up slowly, right? Take their time.
Oh, damn it.
Sit down first, dangle their legs a little bit, walk around, right? And then eat crackers. Very good, yes. Eat crackers.
Okay.
Avoid large portion meals. It's better for them to have, frequent small meals. And avoid food that are greasy and spicy. Okay? So no greasy, no spicy food, and small portion meals. The other thing to remember is when they're eating their food, they have to finish all the solid food first before they actually drink liquid.
Finish all solid foods.
Because if you eat and drink liquid at the same time, you get full faster and they can become nauseous and vomit. So eat all the solid first before what? Drinking. And last but not the least, if that's not really gonna work, then the safest for them is Sofran. Okay? Yes.
The transdermal patch and her weight.
Transdermal patch. That was the question.
Ask the question and if she weighs 260 pounds, she cannot use insurance.
Right.
Because it has to.
Because of the too much fat layer, right? You won't really move. So there you go. So class, that's another one that was asked. If you heard it, there was a question on what can cause the contraception to be least effective for the batch. Overweight. Overweight. So that means a BMI. So overweight is a BMI of 25 to 30. Obese is a BMI of greater than 30. Okay, so the normal BMI, if you look at it, is 18.5 to 24.5. That's the normal. Alright, next, don't forget that on hyperemesis, gravidarum. Okay. Okay, next one. Another one that they're gonna ask you, maternal hypotension. Okay? So don't forget, this one is an easy one. Just pick the answer where the woman, you tell the woman to sleep on their
Side.
left side. Left side, not the right. Okay? Left side. The reason for that is, if you think about it, the left side has the inferior vena cava and the superior vena cava, which presents blood to the heart. So if you're staying on this side, it prevents the blood from going back to the heart. So it's better for them to be what? On their left side. Okay, so don't forget, that's an easy one. Just make sure you teach them to sleep on their
Left side.
left side. Okay, left side lying position to prevent maternal hypotension. Okay. The right is not the best position. Supine can also cause that to happen. The best one is the
Left side.
left. Yep. Alright, let's take a look at this. A nurse is reviewing the record of a client who has just been told that the pregnancy test is positive. The nurse notes that the healthcare provider has documented the presence of girdle. The nurse determines that this sign indicate what? So, other than what, let me ask you first, what sign of pregnancy is girdle? Assumptive?
Probable.
Or
Probable.
Probable. And what is girdle again? The softening of the
Surface.
Okay.
So
What's the name when the cervix becomes violet or purple in color?
Chad.
Alright, angioedema. This one very easy also. Just make sure to remind the woman to elevate their legs and no prolonged standing and sitting.
Elevate legs to prevent ankle.
Supported stockings can be worn. That's your dead toes, right? And again, avoid prolonged sitting and standing. Hemorrhoids, not really much. You know, the question is more on constipation because women actually takes a like prenatal supplement that causes constipation. What is it?
Iron.
Iron, right? So you want to make sure that you tell the woman to hydrate, take a lot of fiber, and to ambulate because iron is constipating. That can already help with hemorrhoids also because they don't have to work strength.
Mm. Constipation due to
Oh, wait. Yes, on breastfeeding, there's a few things. But it's more of the postpartum though, because actually if you think about it, the breast doesn't really get engorged not until 48 hours postpartum. So very important, if they ask what is an effective way of relieving postpartum breast engorgement, other than, of course, the best thing is what? Breastfeeding. Right? So there's also a question which reminds me, because we're already there. They're gonna ask about the best early bonding for mom and babies. Okay, the answer is what? Breastfeeding or skin to skin. Okay, breastfeeding. Right. So, but going back to breastfeeding, other than breastfeeding as the best answer for preventing postpartum breast engorgement, the other one is breast pumps. So look for an answer where you're actually teaching the woman how to use breast pumps. Okay, how to use breast pumps. One of the options that's there usually is to teach the woman to use tight fitting bras. You don't want to fit. Okay, why? If you use tight fitting bras, it will actually stop you from producing milk, and you won't have enough milk anymore for your baby. Yes. Correct. So you want to what? You want to encourage them to use breast pumps. Okay, if they other than of course breastfeed. Yes. All right. The other thing that they're gonna ask you on breast, that one. They're gonna ask you that. So don't forget colostrum. What is colostrum? It is the first breast milk. They're gonna ask you the benefit of colostrum. Yes. Complete on nutrients, complete on antibodies.
Nutrients.
So it gives the baby a lot of good nutrients, especially, you know what, they just came out, they need all of the nutrients they can get. And of course, antibodies from the mom. It protects the baby at an early stage. Okay, before they can start getting, of course, their immunizations. So antibodies is the good source. Colostrum. Okay, now, the other thing that they will ask you, okay, so take note. The benefit of breastfeeding is that it actually decreases the incidence of SIDS. They found out that babies that breastfed are less likely to have the problem of SIDS. So what does SIDS stand for?
Sudden infant death syndrome.
Okay, so they're going to ask you for plan of care for preventing SIDS. So we already know breastfeeding is one of them, right? The other one, don't forget this, right? Don't forget ABC. ABC. So the way it works is they should be alone in their crib, sleeping on their back. So C is the crib. So alone on their back in their crib. Want it to be an empty crib, right? As much as possible, nothing that can fall on the baby. Okay? You want to remove all plastic. Toys, you want to remove it. If you want to have toys, you want to make sure the toy is hanging toys. Brightly colored hanging toys. Why? Because it actually catches the baby's attention and the tendency is for the baby to remain on their back. Okay? So brightly colored hanging toys. Okay, so again, empty crib, nothing that can fall, like paddings, you don't want that. Okay, and you want to make sure that the mattress fits exactly on the size of the crib, so they can't fall in between. Okay,
So maybe what's in the finger?
so again, they should be alone, sleeping on their back,
Some
in
finger
their crib. ABC of 6.
They're all bad.
All right, everyone remembers it?
Yes. Oh yeah, the crib one. Cold crib.
There's the plastic pacifier.
Yeah. So which one was it?
No, close to the window babies, they can die.
Yeah.
That's why
They were all bad. Yeah, down under the vent. No, because of the heat and the cold, like they're not. Yeah. Exactly.
No pillow, yeah, no pillow.
On the back with your
The one finger, right?
So the one finger was the answer?
That won't be enough for them to really fit.
I was gonna get that wrong regardless.
Contraindicated for a topic. Oh, I think that was the discussion on contraception. Contraception puts risk. What contraception though?
Puts the person at risk for
Right.
ectopic pregnancy.
Yes.
Oh, the oral one, right?
Contraception though. Have you guys know what is IUD?
Yes.
Uterine
Device.
intrauterine
Device.
I like out there. Intrauterine device. So there are two types of IUD. There's copper IUD and there's hormonal IUD. Hormonal IUD is made out of estrogen, progesterone, and releases. Copper IUD is made out of copper. What's the thing with copper? It actually it's a sperm killer. Copper. Yeah. You wanna make sure you get some children stay away from copper, guys.
Topic.
The sperm killer. So IUD, because they place it, right? The way they do it is they place it all the way to the uterus, right? If it gets displaced, it actually can scar the fallopian tube. And when the fallopian tube is scarred, the scar tends to cause the egg to stick there. So now, instead of the egg going to the uterus where it can develop, the egg will develop inside the fallopian tube, causing ectopic pregnancy.
Oh, okay.
Okay, so you will see that you have a woman that has a lot of pain and bleeding during the pregnancy. Well, guess what? It's probably ectopic. So that's what causes it. Hormonal and copper causes scars on the fallopian. So it's better to go with, surgical pad, depo, things like that. Or abstinence. Alright. So, next one. Not so much on neck cramp. Just read on it, not really much. Here we go. This is another one.
Oh.
First off, there is a question on that might come out on the other version, which is altered body image. So there's actually two things on altered body image. One is on the topic of anorexia and bulimia nervosa, because they have body dysmorphia, right? And we'll talk about that in mental health. And the other one is altered body image due to pregnancy. There's a lot of changes that can happen to the woman, right? They can have that, the color on their face and cheek. It's called melasma or mask of pregnancy. They can have darker than usual, areola and nipple. You can have the dark line right here in the center, right? You can also have a lot of stretch marks. So, in a sense, it actually alters their what? Body shape. So how do you take care of that as a nurse? What would you teach the patient? That this is
normal.
A normal part of pregnancy and it is temporary.
Temporary.
Although some are not so temporary. In real life, we all know. Some are not so temporary, right? Alright. So what do we do? What do we tell them? It is temporary-ish part of pregnancy. It's not a disease. Okay?
Nice.
Alright, the other one, they're gonna ask you the vertebral change in pregnancy.
Oh,
don't forget,
lordosis.
Right? If it's S-curve, that's scoliosis, right? If it's hunchback, that is kyphosis. If it is lumbar, lordosis. So very easy. Lordosis, lumbar, LL. That's the right answer. So that's the type of curvature change in women. It's lordosis, lumbar curvature. Okay, are we good with that one?
Yes.
Alright, very good. Alright, next one. Rubella. So when should a woman get a rubella shot? After or
30 minutes, 30 days. No, 20
3 months?
or before pregnancy. Correct, yes. So the right answers are two. Either the woman gets it at before pregnancy or after pregnancy. Now the question is, how would they know if they need it? They have to get a titer, right? A blood titer. Right. Once they get the titer, which is what will measure the amount of protection that they have from rubella, then they can make the decision of course, the best is when? Before. Right? The best is before. Now, if they get the rubella shot before pregnancy, they should not get pregnant for at least 28 days. At least 28 days after the shot. Okay? In the old exit and NCLEX, the answer were 3 months.
Yeah, that's what it says right there.
If you don't see 28 days, but there is still an option for 3 months, that's the next best answer.
Or 3 months.
Because that was the old protocol before. The old protocol before was to wait 3 months before you get pregnant if you get the rubella shot. But they changed it to 28. So you see 28, that's the best answer. You don't see 28, but there's 3 months, that's the next best. What if they're all not there? Then pretty much in trouble. You're just gonna have to make a guess. Yeah. Just gonna have to make a guess, alright? Okay, or maybe there's 4 weeks, right? Maybe that's the answer. There's 4 weeks, because 4 weeks is what?
28 days. Ish.
Okay, alright. So other than that, then of course they can get the rubella shot after. Okay, alright, so don't forget that. And then here it is, some of the reportable diseases during pregnancy. Okay, you have gonorrhea, syphilis, herpes, and chlamydia. That's on the question of reportable diseases during pregnancy.
Gonorrhea, syphilis,
So,
herpes, and chlamydia.
Wait.
Why can't I spell today? Chlamydia. Okay.
alright. So next one, we did ultrasound. We talked about that already. Alright, one more. Here we go.
Alpha
The
fetoprotein.
next one, very simple. They'll ask you on what is the purpose of alpha fetoprotein screening. This is to detect possible spina
Bifida.
bifida. Don't forget, what is the best way for a woman to prevent spina bifida on their baby?
Folate.
Folic acid. Very good. It's those two things, remember it, okay? Alpha fetoprotein, it is for the process of detecting your spina bifida. How does a woman prevent spina bifida? Take a lot of your folic acid. Yeah,
To prevent spina bifida.
take a lot of folic acid. That's the best way to prevent neural tube
Defects.
Okay? Alright. You're welcome, guys. So here's your spina bifida.
Ay.
Oh, yeah, they have to stay prone or something.
Amniocentesis,
Non-stress
non-stress
test.
test, and stress test.
Stress.
So just for nutrition, and this is where we'll stop, okay? For nutrition, just don't forget, a woman during pregnancy needs at least 350 calories more than their usual intake. But they should avoid, look at this, average weight gain during pregnancy is only between 25 to 35 pounds. Why? If a woman gains more than 35 pounds weight, they are high risk to develop preeclampsia, eclampsia, and gestational
Diabetes.
Okay, so it's important that they don't gain more than 35 pounds during pregnancy. Okay, and again, eat a lot of fiber, ambulate, drink a lot of fluid, at least 8 to 10 glasses of 8 ounce of water, and then juice, especially what? Vitamin C.
Vitamin C.
Okay, because they're taking
Iron.
iron. Okay. Alright, there you go, guys. Any questions?
Surg.
So tomorrow we'll finish speech and mental.
Kapit na shit.